All right, hello, and welcome to another Down Fracture podcast, a podcast for talking jaws. As always, I'm joined by Dr. Sam Bobek of Seattle Jaw Surgery. This is Dr. Michael Wasson of Arizona Jaw Surgery. Sam, how's it going?
Good, man. It's good to see you. You just came off vacation, yeah?
Yeah, from Disney. How about you? Is it your
No,
whole life a
just
vacation?
yeah, I'm living the dream in Seattle. We had some lightning yesterday. That was very un-Seattle-like, so it's kind of
Yeah,
reminded me of my time in the South. It was cool.
I do. I do remember the first time I saw lightning in Seattle. And it didn't coming from Texas. It didn't like to me. It didn't seem weird, but like everyone was stopped and like out looking out the windows. Like I could barely like walk down the
What is
hallways and stuff.
this? Are the gods fighting? Um,
It
yeah,
was a
so
little
it's pretty
strange.
unusual. So let's see, we
All
got a
right.
full plate today, I think, right?
Yeah, some things to get through. So as always, general housekeeping, downfracturepodcast at gmail.com if you want to email us some stuff. And we did get some emails beyond our normal, just generic fan mail that we get. We got some nice input from another group, actually, a couple surgeons from another reputable jaw surgery group. As I mentioned off screen, I don't know what the decorum is here. I don't want to mention people by name in case that they don't want to be mentioned, but some good points were brought up with regard to the bleeding topic, intraoperative bleeding that we talked about. And one of them was just something we maybe didn't mention or skipped over in general, maybe is implied to some and not others, of like the health history and patient medications make a difference, make sure they're not on any medications that might increase bleeding. And then they brought up a specific topic, which I think does, warrant mentioning, and that was the widespread or increasing use of SSRIs and their known effect on intraoperative bleeding. So I think that's worth bringing up and discussing because they mentioned how they try whenever reasonable and possible to maybe even transition patients off of that in certain circumstances. What's your experience, if any, been with that?
I haven't messed with that. I mean, I'm in a part of the world where that's it's very common to be taking medications to manage, depression, anxiety. And for me, at least, that's one of the more common medical problems to manage after surgery, because the surgery itself can cause kind of quite a disruption in your life. So I'm a little bit reluctant to stop any of those medications. Just because we're kind of more bummed out up here in Seattle. I mean, Arizona and Southern California, I could see it, right? Like, I think it's a good thing to keep in mind. So I definitely appreciate the feedback, and it's something that I think I'll look more into going
Yeah,
forward.
as I was emailing with this group, I mean, I have noticed that at times in my career. I guess it just never really crossed my mind that it was so significant that I would stop it because as they rightfully pointed out, the people who need it the most are on the highest doses, and you can't simply stop them for a period of
Yeah.
time like an aspirin or things of that nature. And so you either have to transition to other meds or manage them in other ways, and that's not always simple, easy. So I always felt like I could mostly manage it intraoperatively, but I definitely noticed that in my career,
Hmm.
that association, but never, I guess, never so drastic to where I guess even put it as something significant that I would need to address. But it only takes a time or two for that to be a big deal for me to maybe change my mind.
Yeah. Definitely good thing to note on the medical history and kind of managing things before going to the theater, the OR. So,
Theater. Are you
I
British
got a little
today?
British there. It was just I'm not sure where that came from really. I was hanging out with Andrea here. I wanted to sound fancy. So we have a guest, and I
Uh,
was trying to up our dialogue a little bit. Didn't go well.
I guess the only other thing would be there was also a question about potential suture abscess and closure of specifically TMJ replacement. I think there was someone was asking about how they've had a recent maybe increase in what they perceive to be suture abscesses from that, and we're asking questions on how we close things. And I, again, kind of a similar thing. It's certainly something that I've encountered, but I've never recalled that being all that prevalent for me. So maybe it was just a bad suture batch, like that person
Well,
said that it might be.
yeah, I mean, in terms of that, I thought on that topic, that related more to the timing of closure, that being towards the end of the case. because it's not an unusual technique. I mean, I think we both practice that you do one side and close it and do the other side and close it. Do you just close everything at the end, or
No, I actually do everything at the end. I do
oh,
everything
you
at the
do?
end.
Yeah, so let's say you just do everything at the end. So the closure of the surgery is at the end, and by then you've already been operating for a period of time. You might be tired. I bet you fatigue
Absolutely.
plays a role in stitch abscesses for TTR. Because
No doubt.
it's you're gonna get tired. And I think taking breaks and just being aware of it or having other people help you out with closure, those sort of things are gonna be helpful.
Yeah, I think that is to me, that's the most painful part of that. Just closing everything is just so painful at
Try
times.
closing
And
a side, put a joint in and close it, and then do the other one and close it. It's pretty
I
nice
mean, I
actually.
mean, it's worth trying. And that was the last point I was going to bring up about stuff from previous episodes is when we were talking about bleeding, we had the point of the SSRIs and other things. The other point that I don't think we talked about, but I think makes a difference, and I think, did it differently previous, is with regards to bleeding. I think it makes a difference to close the jaw that you finish and not just close everything at the end, kind of like you're saying with TMJR, because where you previously trained, if I remember correctly, didn't you close it like you just did everything and closed everything at the end instead of do your first jaw, close that jaw, do the
Yeah,
second jaw, close that jaw? I
yeah,
think that
because
makes a difference in bleeding.
definitely. I mean, I mean, probably. I think it makes a difference for things like infection or other things getting into there, like brackets and rubber bands and stuff into your surgical wounds. But yeah, I came to Seattle and I watched uh, Gary Feldman operate. Like I was like, I want to see some of these guys that have been here a long time just to see how they do things. And one of the things I picked up on immediately was his closure of the mandible after doing it and then going to the maxilla rather than just closing everything. And anyway, I felt like I learned 3 or 4 tips I use to this day just by witnessing a seasoned operator do some things. So
Yeah.
anyway,
All right. Well, let's, I guess, shift gears onto our topic today, which is with our special guest. I'll let you introduce our
yeah, our
special
special
guest.
guest comes in from the distant land of Seattle. So it's Andrea. She's sitting here. We work together. So we've been practicing together for 7 years. We're in our 8th year working together. And so Andrea is a physician assistant. She's sitting next to me here. And so our topic I thought would be good is integrating physician assistants to jaw surgery practices. Because I think you get exposed to PAs and training in terms of general surgery, surgical ICU, head and neck surgery. I think there's some spots that use PAs in trauma. Is that right? Probably. I don't know about maxillofacial, but general trauma for sure. And so I think jaw surgery, orthognathic surgery, TMJ surgery sets up really well for bringing PAs in. So anyway, brought Andrea here. She was nice enough to agree to join us. So Andrea will tell us a little bit about like her background and how she came about this sort of thing. So
yeah, just wanted to say thanks for having me. I know Dr. Wasson likes old-timey sayings. What is it? Long-time listener, first-time caller.
Oh, I
nice.
love it.
That was like what is it talking? The car talk? That's like a car talk.
Yeah.
Yeah. Yeah. I mean,
She knows how to butter me up, Sam.
but yeah, I'm a PA. I've been with Dr. Bobek for about 7 years. Originally, I worked in ENT head and neck surgery for about 2 years before my now husband and I moved out to Seattle. And that's when I first kind of learned about maxillofacial surgery. Prior to that, I didn't really know what was involved with that at all. But this was when Sam was with Swedish. And so I was looking at their job postings and there was like a head and neck position open, which was being filled, but they were like, oh, we have a maxillofacial surgeon who's looking for a PA. And I didn't know what that was, except for it's kind of head and neck region. And that's kind of how we first connected.
Yeah, because at that time it wasn't very common at all. I'm not sure if there were practices or if there's only a handful that were kind of using PA in the orthognathic surgery world or the TMJ surgery world. And I mean, over the years, it's worked out great. I mean, in terms of integrating and the utility of it, it makes more and more sense as time goes on. So kind of talking about how that works, I think is important because the future of healthcare is certainly integrating, I don't want to say the wrong word, mid-level providers. Is that what we decided is okay to say?
I think so.
It's okay with
Whatever it
me.
is, you know, the associate, the nurse practitioner PA world, right?
Yeah.
So,
Yeah.
Right.
And so I think part of it was just, I feel like maxillofacial world doesn't really know that much about PAs besides your exposure in training and things like that. But you'd worked with the other ENT PA for a bit, and that's where I kind of, my job position was started. But it was a little bit of a learning curve initially for both of us. In PA world, our training is, we have an undergraduate degree, then you get some clinical experience in something like, I did ER tech and EMT for a while. And then PA school is a graduate program. So it's about like 2.5 years of just kind of program, and it's modeled after medical school. So it's like a didactic program and then rotations and training. So we do general surgery, pediatrics, women's health, things like that. And I just kind of had a special interest in surgery after doing some rotations. So that's kind of how I got started with head and neck and things like that. And I think one of the biggest things is just kind of how PAs are trained as generalists, so we can kind of work in all different specialties, but I think getting it to maxillofacial of kind of being more of a dental specialty is where it's a little bit more unique.
yeah, because what's your experience, Wasson, in terms of working with PAs?
Working with PAs, I think I mentioned this to you guys yesterday, in that I don't think I really worked with them or noticed that I was working with them until I rotated down to Oregon with your previous practice and residency program, and they were basically running the trauma service from the, like, on the floor and standpoint. And so the system there, as it is in some places, was if it's a trauma patient, they're just admitted to the trauma service, and it's helpful to all the other trauma specialties in that they don't have to manage the day-to-day minutia of the patients. But whenever I would, my experience, I would often be calling a resident in my own training program of like trying to get in touch with the resident, figure out what's going on. And that was often difficult because the resident might also, be in the OR or down in the ER. And also, there's turnover. The resident you were talking to yesterday may now be on a different rotation and things like that. And so I found it kind of refreshing that they both, the level of continuity of care and familiarity with the patients was nice, but it was a new phenomenon to me, and I was a little uncertain how to interact with them. Not like on a degrading or insulting level. It's just like I don't know. I would talk to an attending different than I would talk to a chief resident, different than I would talk to an intern, different than I would talk to a nurse. Like there's levels of understanding and knowing what each person's role is. I might have different questions, concerns, information to relay based on who I was talking to. And I found that to be a little difficult in the beginning. I don't know, was your experience similar?
Yeah, I mean, because it was kind of I feel like it was a new thing. How long have PAs been around?
PAs, it started, I looked this up, Duke University in 1965 was when it started. But I mean, also pretty new. Like that's not that long ago.
Yeah, but I mean, I don't know. I just it definitely has felt like it's much more common to see PAs in ICUs and in urgent care and in ER.
No doubt.
You just talk to whoever, the hospitalist service, and they have a PA helping you out, like those sort of things. Like it just
it's
seems
definitely
more
becoming more
widespread.
common.
So because I agree. I mean, I see it because when like when you're a resident, you see kind of interact with PAs a little bit different. But as an attending, and then as you get into practice, because all the things that you had kind of depended on residents for in residency, like more junior residents and or senior residents, you can find someone that just knows that stuff and they're always working, right? So you train, and then that information is always there. So if I was a resident, I would go to the PA for sure to get the info of how to do stuff, because they're like the expert resident, right? Like they know everything about how to manage the service. And so
well, I mean, generally the PA's been there for hopefully a number of years, so they kind of have that baseline of kind of knowing the inner workings of the hospital system or the nurses or the attendings, the surgical service, and kind of know where things are located in the OR, like you need supplies or different things like that. I think that that's really helpful.
Yeah, no, I mean, that stuff's really important. And I think when it comes to orthognathic surgery or jaw surgery, it's like things I hear is, you know, like how does it work? Because there isn't like a, you know, there's not like round, I guess you round on a patient or two, but it's not like you have a big service to manage. So, you know, is it really worth it if you're doing a smaller volume of cases? And I would argue it is, because at least my impression of PA world is there's people who go to the OR and then there's people who do clinic. Is that's pretty fair?
Yeah, I
Or
think it
hybrid?
depends on the surgical service. Where yeah, some people are more clinic based and some OR based, but overall, I think I was looking for something that had a combo of both because I liked both. But some services split it up.
Yeah, so for
Yeah, so
yeah, go ahead.
I'm
Go
sorry,
ahead.
go. I was just going to say, could you one or both of you, but specifically Andrea, you know, maybe I think one common issue that I was kind of getting at is you don't want to be degrading, insulting to someone, but I think my one of my issues with dealing with PAs when I first started dealing with them is I truly was ignorant to what they can and can't do. Can you kind of go into that? Like I don't know, are there do you have kind of just really broad general restrictions or limitations in any way? Or if since you're essentially have to have like a supervision agreement with a physician,
Mhm.
is that at the discretion of the physician? Like, can you suture? Can you operate? Can you like what are your limitations, restrictions, or maybe even in the opposite form, like what all are you allowed to do? Because
Yeah.
I think that would better help people understand how they could potentially incorporate a physician assistant into their practice.
Yeah, and I think it varies a little bit by specialty. So I'm not really going to touch on like primary care PAs and things like that, just kind of focus more on surgical PAs. But we can see patients independently, you know, see new consults and things like that. You can order tests, like order x-rays, order blood work, all of that stuff. I have my own DEA, so I can prescribe medications and things like that. Have my own NPI, like all of that stuff is tracked otherwise. And then we can assist in surgery. And that is that's more of the direct supervision with your supervising physician of like what I can do in the operating room is very dependent on what Dr. Bobek is comfortable with me doing or kind of what our understanding is of that. So it's under his supervision of what I do in the OR.
But
And
there's
then
not like a firm like cutoff point, essentially. Like if
no,
he was
not that I
fine with
know
you
of. Yeah, he's doing all of the
doing
main
whatever.
operating, but like, you know, with suturing, I do, you know, closing aside and things like that. I do the abdominal fat graft harvesting for TJR patients or open arthroplasties and things like that. So I can perform kind of more basic procedures. I can also do that independently in clinic, like removing a mucocele or something like that, like more like a tongue biopsy. Like I can do that with a dental assistant. That's fine. Anything, you know, and it's more of his and I discretion of if it's a little bit more complex, then they should be seeing the surgeon, you know,
Right.
and that's more with
Okay.
just with time, kind of building that relationship.
And I mean, our schedule is very much the same. It's
Mhm.
not completely the same, but it's largely like we're doing the same thing. Like we're in the OR together, we're in clinic together, right? So there's
Mhm.
overlap and there's, you know, because it takes a while to train and be comfortable, and you know how it
Yeah,
goes. There's
absolutely.
new things
But
that come up that the
in
schedule.
theory, you know, I don't, it's nice to hear you guys' own personal experience, but I mean, I don't want to make it all about you or all the minutiae or details of how you guys interact. But in general terms, again, in theory, you could function similar to a resident or someone else. Like Sam, if you had to go or you went on vacation and you could see follow-up patients in the clinic by yourself, things of that nature. You could round on patients and put in orders and all the things you were kind of mentioning with your own NPI, DEA. Like
Yeah.
that's true,
Mhm.
correct? Like if you had to operate at one hospital on Tuesday, but your next surgery was on Wednesday, Andrea could, in theory, go round on the Tuesday patient while you're getting Wednesday set up at the other place and then come join you. Things like that, like would be a very valuable utility for someone,
Well, yeah,
correct?
And that's what we've done over the years.
yeah, for
Yeah.
sure. And I mean, because there's definitely a gap in jaw surgery world in being able to perform the surgeries, right? Like if you join a practice that does jaw surgery, you're just going to operate with the senior person. and learn the skills. You'll have 2 surgeon operating, and then you'll have a seasoned dental assistant helping you out, right? That's how you learn it in residency. That's how you do it in fellowship. But there's the gap of, what if you practice on your own, or what if you're in a group where you're the only one that wants to go to the OR, right? Then you're going to bring in a dental assistant or 2 dental assistants, and there can be churn there. And if you're not doing enough volume, it's like, it's hard to train and that sort of thing. Whereas if you bring another provider onto your clinic, you have another provider that will get up to speed so you can operate the case with them. You can also bill for them. They'll help you with orders. They'll help you manage, pre-op, post-op, just kind of like help out in the perioperative care. And it is way better to have 2 sets of eyes on a patient than 1 set of eyes, like for sure. I think that's what I have over the years really appreciated in terms of, because what it's like. You practice on your own. You don't know when you're wrong, right? Like, or when you're missing something. And so it's nice to have another set of eyes helping you out with that, and some seasoned, kind of more trained eyes than, necessarily a dental assistant is a sneaky benefit of working with the PA. So.
Got it.
I think also offering like some medical training background of having a training program of, I think I get a lot of benefit from working in ENT head and neck prior to coming here, because I use a lot of that knowledge with like TMJ patients and their ear symptoms, or jaw surgery patients and their like nasal concerns and things like that. Like, I have that background of like, oh, okay, you need this, or just looking at an ear and doing a good ear exam of like, oh, you have otitis externa, that's not your jaw joint, things like that I think are really helpful, and things
No
that I
doubt.
can add with experience.
Okay. What else did you have, like other information that you think we would want to hear about? So we went through kind of training and how you would get to be incorporated into a jaw surgery practice, kind of how you guys utilize you. What would maybe, and you kind of touched on some of this, but what would a PA, let's assume, of all of our listeners, which they're becoming, almost impossible to count at this point. But what if, let's assume 1 to 2,000 of them are physician's assistants. What do you think they would want to know? Like, why would they be interested in this, or what would they need to know? Or let's maybe even make it the generic question of, hey, I'm a physician assistant, I'm going to graduate soon, and I want to get into maxillofacial surgery. What would you think they would want to know or need to know?
Yeah. And I think it goes both ways of like, maxillofacial surgeon looking for a PA, like what should I look for in kind of qualities for a candidate? And so from the PA's perspective, I think maxillofacial is great in, if you like operating, finding a surgeon who operates and needs help, I think is how we kind of started with my position, of like being in the OR and being a part of patient cases is really a great utilization of a PA. But I think one of the things that I had to learn was the dental stuff, kind of all about teeth and oral stuff, because I didn't go to dental school. I don't have any of that training. So I've had to learn that throughout the years. And I think that was the biggest kind of learning curve when I started.
Yeah, it seems like actually, well, the PAs that I've worked with, the dental stuff seems like as much of a black box as it is in medical school.
Yeah.
When you're in med school and you're talking to other med students, they're training in things dental related, or oral exams is not good. And so they just kind of like gloss over it because there's another specialty that manages it. And so I feel like that's true with PA.
Yeah. When I was in ENT, if it was something that was involved with the jaws, it was like, oh, go see the maxillofacial surgeon. Like, we're not gonna, if it was a tooth thing or something like that, maybe a dental abscess, like go see your dentist. Like, we're not gonna even try and diagnose that or treat that at all. So I think that was the biggest learning curve that I had to kind of learn as I came on. But I think kind of what was helpful is that I had worked in a different surgical specialty prior to coming here. I think that really helped me a lot in knowing what I could do and kind of like the role of how I could help this clinic and this practice. Because I think that was one of the things when I came on was, okay, what can I do to help make this clinic more efficient, allow Sam to see more consults? What can I take over? And I think that was kind of what we sorted out throughout the years of, okay, I can do the pre-op discussions with patients of like, teaching them what goes on with surgery, what to expect with recovery. I think that that's been really helpful to kind of build that relationship with patients as well prior to surgery, from my perspective. And then I see the new like TMJ consults that haven't really seen any other people. So kind of more of the primary care TMJ consults, they'll see me first, to kind of weed through people who need surgery versus people who can do more like PT and things like that. So I think those are things throughout the years that we kind of figured out what I would see. And then post-op cares, I think, is a big part of our practice of seeing post-op patients, kind of giving them a pep talk of getting them through recovery and things like that. And then assisting in surgery is kind of the key things that I do.
Okay. What about like call for the practice or anything like that? Are you involved in that aspect of things, like managing post-op calls on nights, weekends, etc.?
Yes.
Yeah, I mean, definitely, Andrea helps out with that. In the past, there wasn't much, but that's kind of been a more recent change. I'm still around to kind of back up because, I mean, the supervision thing still is true, right? So, we need that. So if out of town otherwise, and you have someone in town who can supervise locally if something happens, right? But Andrea does help out with call, which is great. And I mean, she has, remote access, the ability to manage medications, and seasoned enough to understand when stuff's crazy or when it's not crazy, right? Like, and again, it's like from my side, in terms of surgery side, you have a seasoned resident always working with you, right? Like once you train them up, they're always there. And they go on vacation, and Andrew's got a bun in the oven. There's real life that happens, right? But that real life still happens with residents and everything else. And so you have someone that understands the process and understands kind of like how you do things, and caring for patients. The quality is it's just better. And I'm a big proponent of integration of PAs, because especially in jaw surgery world, it helps a ton. The non-surgical thing, by the way, the non-surgical TMJ care, because it's different in state to state, but there's a gap there, right? Like people who go to their ear, nose, and throat doc, or go to their PA, or not, I'm sorry, their nurse practitioner, their primary care doctor, whoever that is. They want to refer someone for non-surgical TMJ issues, and there's a handful of dentists that do that, but it's unclear if they're networked with insurance, or how medical referrals work to dental practices. Andrea helps a ton with that. She takes all of our primary care TMJ referrals. I see TMJ referrals from surgeons, and otherwise they go through Andrea. She can set up MRIs, she can set up physical therapy, she can get Botox, she can help people with just common sense things. And if it's like, hey, a splint's the right way to go, or you should see an orthodontist, she sends them that way, right? Like that's like a sneaky need in maxillofacial world, like oral and maxillofacial surgery, and actually dentistry in general needs that support, because there's a group of patients that just tough it out, so that's been, I don't know, when did that change? Like 4 or 5 years ago?
Yeah, I feel like I've at least 5. But that was pretty
somewhere
early
along
that, yeah. Pretty early that I took over those TMJ patient kind of referrals, which I think has been for the better. Because a lot of the times I can tell by their story, their exam, things like that, of like, oh, this is more, anatomic, this is more surgery, let's get you an MRI, let's have you follow up with Dr. Bobek. And they go on to surgery, versus the other people that I send for PT, or do some Botox and help with their clenching and just kind of all of that stuff. So yeah, that's been really helpful.
I think, Wasson, we've talked before, the thing that's keeping you away from hiring a PA is the physician part, right?
Yeah, but that was one of the topics I wanted to get into with you guys, and we briefly talked about it in our 4-hour preparation window for this podcast. In that and Andrea, I think, mentioned this a little bit earlier, in that the rules and regulations differ state to state. And I did not look them up recently for Arizona, but I looked it up a while ago. And I think for both I think it's actually down here, it's less strict on nurse practitioners, to where like if they've worked something like 8,000 hours under supervision, then they can then go out and essentially practice on their own. So like a nurse practitioner could hang a shingle, so to speak, and have a primary care women's health type practice or whatever, pediatric, whatever it would be.
Yep.
So in theory, a nurse practitioner in my world that had that level of experience could join me, because they don't have to have any supervision directly. I think they're still supposed to have like an agreement with like a physician or physicians group to where like, hey, if something really goes south, like we have an agreement to where we can get them to you or we can get input from you. And it seemed like the world of physicians assistants was maybe even more strictly regulated. Like maybe a physician assistant could not do that. Is that
Yeah.
your understanding as well?
Yeah, I think that it has to do with the licensing of things. Nurse practitioners are independent providers, I believe. Don't quote me on the terminology of that,
Sure.
but they do not have to have a direct supervising physician, I believe. And versus PAs, that's kind of with our training, kind of how the profession was started, is that you have that supervising physician role, and that can be like a remote supervising physician and things like that. But I do think that the licensing, when we looked it up in Washington, it needed to be an MD or a DO as a supervising physician. And so that would be probably the biggest limitation in getting more PAs into maxillofacial of, if it's a DDS, I don't think that licensing works for
Right.
state board. And it would be kind of state to state to look into.
Yeah. So to answer your question, Sam, yeah, that would be one of the barriers, because I also think, and I'm going to be candid, and maybe Andrea, you can chime in with this, but I don't fully understand how everything works in their worlds, but it seems like a physician assistant is probably a better fit in a maxillofacial surgery practice, because they are probably doing more surgery and managing patients on an inpatient level, whereas a nurse practitioner maybe is not doing as much of the like hands-on.
Yeah, I
Maybe
think in
even-
training, PAs generally have more training in surgery and have an easier time getting into surgical specialties. That being said, there are nurse practitioners that work in surgery, and I think that they're just more motivated and they kind of seek that out. So I think it's possible. I just don't think it's as common that they have surgical training prior.
Yeah, my experience
Would be
was
the
in
biggest thing.
some surgery clinics that they work in the clinic, but maybe don't like go to the operating room and other
Yeah.
things.
But
Is
they
that kind of
could.
what?
I think
Yeah.
if they had interest and you could train them, they could. I don't
Yeah.
think that there's like a licensing limitation against that, but there are
Sure.
nurse practitioners, I don't know as well, but there are limitations on like age ranges that they can see. I don't know. It gets complicated. That'd be another topic. But
It does.
I think that could be a possibility of like mid-levels in maxillofacial of nurse practitioner could overcome that like dental kind of supervising physician need, because they don't need one. But I think that's the biggest restriction for PAs in maxillofacial is just the licensing.
Yeah, you should start some kind of movement in the
Yeah.
PA world to allow that.
Yeah, I could start talking to the National Association.
Yeah.
I'll just
I
write them
can
an
only
email.
imagine
Yeah,
what kind of
phone call.
shitstorm that would stir
Yeah.
up in terms of, like mid-level in dentistry. That's
Yeah.
the topic that was.
Oh, but I mean, like, does
Can't
it have
talk
to be
about.
dentistry as a whole? Like, I mean, I realize us single degree guys in maxillofacial surgery are kind of in this weird area, because we are only dentally educated, but we're more medically surgically trained. Like, I mean, whenever I try to tell people and explain it to them, I'm like, in my residency of 4 years, I think I spent 4 months in the dental school. Otherwise, I was in the hospital, for 44 months. I spent more time with the general surgeons, the plastic surgeons, the orthopedic surgeons than I did dentists. And we essentially, even in single degree, we function essentially as physicians within a hospital system, right? Like I'm not,
Yeah.
I can admit, consult, H&P, all these things. Like we're essentially functioning as physicians. So I don't see why. I don't feel like it would be that big of a leap to allow physicians assistants to work with oral and maxillofacial surgeons. Yeah, now trying to put them in like an endo office and allow stuff like that, like I think you're getting into weird territory there.
Yeah.
But I don't feel like it would be that big of a deal.
Yeah, I mean, if you could just stick it stay with oral surgery, then for sure I agree.
Mhm.
Because I mean it's a little bit silly. I mean, I honestly don't feel like I'm getting some increased information because I went to medical school that, I can work with Andrea that I wouldn't have had that if, I didn't go to medical school, you know what I mean?
Right.
But regulations are real. And so you just want to make sure you're on the up and up in terms of bringing somebody into your
Yeah.
practice. So
Oh yeah, no doubt. I'm not saying break the rules. I'm just saying, food for thought, Andrea, if you wanted to make a difference in the world.
Are you saying if I want to move down to Arizona and
you don't get
No,
sneaky.
work with you?
Arizona,
you don't
it's
want
just
to,
too
you don't
hot.
want to do that.
Look,
You
air
don't.
conditioning is bad for the world. So they're gonna run out of water. Like there's a lot of reasons not to do it. No, but I think in terms of PA integration, I think for who like who I think we're talking to with this podcast, it makes a lot of sense. So for people who are doing orthognathic and TMJ surgery, having another person who's skilled that can help you out is I think the right level over resident and over another surgeon. So
Yeah, I think in the spirit of our podcast being kind of a real talk, so to speak, as the kids say, no cap, with appropriate riz. Um,
I'm not
other
sure it's all what you
barrier,
said there.
I'm not either, actually. Hopefully, I didn't just insult some ethnicity or something. But what I would ask is, and I don't want specifics of your practice and anything like that, but Andrea, in general, like what would be the expectation for compensation, work hours, benefits, et cetera, from a physician assistant standpoint? Because that differs for a dental assistant versus a PA versus nurse practitioner, resident, fellow. Like again, I don't want to know your specifics, and I'm sure everything changes with experience and tenure and longevity and everything. But do physician's assistants make 80 to 120? Is the expectation that you would always have health insurance, dental insurance, paid vacation? Like, is there expectations from a physician assistant standpoint as to what would be available in the realm of compensation?
Yeah. I think that's a little tricky. It varies where you are in the country, I would say, with like PA compensation.
Kind of sweet. Or how does the hospital?
How does the
Like
hospital
generally,
feel?
like
Yeah.
hospitals are employing a lot
Sure.
of PAs, or big medical groups are.
And I think surgical PAs generally get higher compensation. I would say roughly, I mean, now it's looking at like 130 would probably be the minimum of like you're starting out of, a program and you're starting in a surgical specialty. And then with experience, I think that goes up to like 190 of like
Okay.
seasoned surgical, experience. And then, yeah, I think most PAs would want some type of medical insurance benefit, and then PTO and things like that. I think as if you were a provider,
Yeah. Well, I mean, I think
Um,
just in general, you give that to most of your employees
yeah.
anyways. But
I think the other thing that hospitals typically have is like some CME, like time for CME, and then a budget for CME yearly. I think is pretty included, and then like covering like licensing, like DEA license or state licensing and national, because ours are the same as like physicians of like every year, every 2 years, you have to like pay your licensing dues and things like that. So.
sure.
Mhm.
I mean, it would be like paying a resident, right? Like if
Mhm.
you were just going to hire a resident to
Yeah.
work with you or a fellow or.
Yeah. So, I mean, I guess that would be, we've talked about a number of topics, but just to kind of keep it in this, like in this thread and to maybe bring it home a little bit. So for both of you, or maybe start with Sam, like, where is the return on investment to that? So
Mhm.
like, you're spending that every year, and then assuming it goes, but at the same time, salary increases, I would expect the physician assistant's role is taking on more responsibilities, more familiarity, doing more tasks. So you're probably, the increases are probably easy to accept. But where did you specifically see the return on investment to that investment? Because that's not nothing for a lot of practices,
Mhm.
to just say, hey, I'm going to take on that level of compensation in
Sure.
perpetuity.
Yeah. So, I mean, because it's comparing to what you would be doing otherwise, right? And so when it comes to dental assistants or oral surgery assistants, at least in my neck of the woods, after the pandemic, the rate that you're paying that group of people is substantially different, like it has an increased rate. And so if I'm bringing 1 or 2 oral surgery assistants to the OR to assist, that's really what you should compare to. And the other part of it is if you had another surgeon, right? Another surgeon is much more expensive, right? So if it's once something's less or something's more, you have this in between ground where you can work with someone and make the finances make sense, because helping out in clinic and in the OR while also billing, there's a revenue stream that kind of offsets the increased cost from, let's say, a couple dental assistants. So it depends a little bit on the situation. For my world, though, the part of just making my life better, I mean, I'm much more interested in that now than I was when I first started working with Andrea, because I trained to work too hard. But you know, a PA helps a ton. It's like you know, another view with interacting with the hospital and the nurses and the scrub techs, just getting the room set up, just kind of like the intangibles help you so much. I mean, that alone, once you start working with someone, like, I don't know, for me, that makes a ton of sense. So independent of the finance part, it's just so helpful for surgeries. So
Yeah. And then, you know, like you said, different than a resident or a fellow, they don't leave after a few months or a year or whatever, and you're not retraining someone over and over and over again to help you.
yeah, because there's that sweet spot where you work with residents that, you know, they're interested, you get them trained up, and then you do cases with them, and it's great. And it's great. Like I remember that as a resident, I remember as attending. But you know, the world's a different place when it comes to things like how much training people have coming into it and just kind of rotation length and everything else, which is a different topic. But having another seasoned set of hands go to the OR, because you can build off of that, right? Like you can take increasing case complexity if you have seasoned hands to help you out with it. Because it is different what you can take on if I'm setting up instruments, I'm instructing people, you know, I don't have another set of eyes on the surgical field, another seasoned set of eyes versus, you know, Andrea helps me out, and you know, she's there's someone with a retainer in yesterday, like a bonded lingual retainer. There's a surgery first case, and she was like, you know, noticed that and pointed it out, and it was holding up our segmental effort, like little stuff like that, which that isn't a big deal, but it's nice to have extra eyes, right? It's nice to have extra seasoned eyes in the OR. So I think when it comes to how it makes sense financially, don't forget about the intangible part.
And I think one of the things that I've tried to do since I've come on is like ways that I can free up Sam's time of, like, you know, getting more time for consults or taking, you know, parts of the pre-op visit or things like that, that he doesn't need to be there explaining like diet instructions to patients. Like I can do that so that he has more time to see other people. Like that frees up his time as well. And then like putting in hospital orders or other things of like discharge orders, all of that stuff is like a time saver in that way. And so it's kind of that offsets the kind of cost of my role, I think.
Because, you know, you get to a point like, and it's, you know, making your life better and making patient care better is worth it. So those are,
Yeah. What
solid.
obstacles did you guys have? Like, do patients, you know, like I guess I could see if I'm a patient walking into a jaw surgery office to see Dr. Bobek, and then I'm seeing Andrea. Like, do you encounter obstacles with that? Do you like introduce her early on so that they know who she is every time that they see her? Like, did you have pushback from nursing staff, operating room staff of like knowing her role or what she can do? Like, did you have obstacles in those regards to implementing her in the practice?
I mean, yeah, I would say, yeah. I mean, it's easier
Yeah.
at the hospital than it is in clinic, right? I mean, the hospital, it's just normal for surgeons to show up with PAs. And I mean, from a nursing side and the hospital side, it almost like
I think
makes you seem like you're more normal if you show up with a PA. You know
I
what I
think
mean?
they generally like asking me questions at the hospital more than kind of asking.
Well, I've
I
met
mean,
fair.
just
Sam,
a little bit
so
more approachable,
Yeah,
right?
yeah.
And I mean, Andrew's like, nicer and anyway, smaller.
Brings cookies.
Yeah, like Midwest, pleasant, you know. And so, but for clinic, it's definitely like it's a balance, right? Like we do things right and wrong. It's when it comes to the different groups. So for TMJ, typically Andrew is meeting them at the beginning. From jaw surgery, I'm meeting them at the beginning, and I meet with them 2 or 3 times before they even meet Andrea. They meet her typically at the pre-op visit.
Yeah.
And then the day of surgery, then after surgery, and those sort of things. And kind of integrating that because in orthopedic surgery, you commonly don't see the surgeon at all after surgery. Like you just see the PA.
Mhm.
And I've received and heard the feedback that it's that's not the best model. So when it was higher volume or when we were really kind of focusing in that way, I like seeing people after surgery. I keep an eye on them on x-rays and pictures, but touching base with them is important as well. So
I think, yeah, that's kind of what we've kind of ebbed and flowed over the years. But I think for me, establishing that relationship with patients at the pre-op visit so that they know that I'm part of the surgical team, I have the experience, I know what I'm talking about, and then it's not a new face that they're just meeting at the hospital or they're just meeting at their 1-week post-op visit. They've seen me before, we've talked to each other. I've talked to them about their medications, about their surgery, all of that stuff so that they know that I'm integrated in the team. And I think that building that relationship from the start, like prior to their surgery, makes a huge difference with them trusting me afterwards to being part of their like post-operative care.
I mean,
sure.
Wasson, you remember as resident, I remember meeting families in the pre-op area for the first time, and I was like getting consent. It was, what are we doing?
So awkward, man.
So
And like
awkward.
when I work with residents now, I try to avoid that, man. I'm like, I'll go talk to the family, like I'll do these things. Like it's just that's such an awkward place to put a resident in. And for the patient and the family too, right? It's like, what's going on? Like I thought I was seeing Dr. So and so, like who's doing what? I mean, they're already stressed enough when residents are involved, right? Like who's doing the case, who's operating, like are they watching, are they doing the case? Like, and you throw that ringer at everybody, and it's just, ugh, yeah,
And then
that's
I think the other time that we've had some pushback is with TMJ patients, but the other thing is when they're scheduled, they are told whether they're scheduled with me for their initial consult or if they're scheduled with Dr. Bobek. So that is like set in place when they set the appointment of they know who they're seeing. So then they don't show up and they're surprised of I walk into the room and they're like, oh, I thought I was seeing Dr. Bobek. And it's like, no, you were scheduled with me. I don't have to do any of that hassle because they know ahead of time who they're scheduled with.
And I mean, I think part of the TMJ thing, I mean, honestly, if you have a relatively early internal derangement or you're kind of looking for non-surgical fixes, talking to me is the wrong person to talk to.
Yeah.
Just because, it's not like I don't know those things, but I'll talk about surgical ways to make this better. And if it's like I'm actually not looking for any surgical ways, you should talk to Andrea, right? Like, I mean, getting people to the point of imaging and then I can talk with them and they've already tried some other interventions. I understand at the beginning, it may not seem like the right path, but it's the right path.
Yeah.
So
got it. Andrea, would you consider like if Sam is the father of Seattle jaw surgery, do you consider yourself the mother?
I don't know if I like that
I don't like the
comparison at
gender
all.
part
Yeah.
of that at all. It's
Okay.
uncomfortable.
Well, what would you consider yourself then?
I feel like I connect a lot of the office. Like I try and oversee kind of the schedule things, connect with the dental assistants, front desk. Like I try and help to keep things running to make it as smooth as possible.
So like the
So
crazy aunt or
I don't know.
I mean, everything Andrew just said made me think more mother anyway.
No, I was just thinking the same
Yeah, I
thing.
just I want
the family comparison.
Yeah,
That's
that's
not
uncomfortable.
good.
Yeah, I mean, I think that Andrew's played a very important role for the clinic and my practice in particular being able to look after the people we look after. Because I mean, I actually don't see it as my practice. I see it as our practice. And that, you're working with another professional, right? And Andrew's got a family, has a life. This is her profession. This is her practice as much as it's my practice. So it's I don't know. I think from my perspective of the overall clinic, I don't know how I would see things without Andrew or without a PA with it, because just wouldn't make sense. So
And I think
Do
that
you, oh, go ahead.
consistency has allowed us to have kind of better patient care in general. Like we see people back that we operated on 5 years ago and I'm still seeing them. And I think that continuity of like, we haven't changed. We're still here. There's been a lot of changes with the practice, but like the fundamental foundation has been the same.
Yeah.
I think has been really good.
Would you say that you help prevent Sam getting too big for his britches?
I don't know about that, but
That's a tough task. Are you familiar with that one, Sam?
yeah, I know that one. I don't think I run into that trouble too much, but I think from the like the other things that are great, because I mean I find myself totally getting in my own head, right? Like I bet this is true for you as well, where you think things are good ideas and it bounces around inside your head and you think it's even a better idea. And maybe the people you talk to would also support it. It's great to have someone in it outside of your head who's like, what's going on here? Why are we doing segmental mandible on this one? Like, what's up with the 4-piece? Like,
I think sometimes there are surgical plans that I'm like, wait, what are you trying to do?
and then I also in my mind after a while I hear Andrea saying, "Don't do this," or "Yeah, this one's going to be okay," or you should add another extra time for this. You know what I mean? Like the
Right.
real life, like, hey, there's another person who's looking at this, because that's great. Actually, I think that's good because
Oh, no doubt. No doubt. You can certainly go down rabbit holes in those if you're talking about surgical planning, and especially you who just like I think you make up new things to do constantly.
no, there's cooler ways to do stuff. It's all I see. But anyway, the from the viewpoint of extra eyes, I think that's great. And my last one is I'm into breaks now. I'm not 100% into breaks, but surgeons taking breaks during surgery I think is a good goal, and still keeping the surgery going because Andrew's working is a nice part.
Mhm.
What do you think my break rate is now, though? It's still pretty low.
I mean, I think that you should actually sit down when I'm closing the fat graft versus hovering.
I intend to take breaks though. And I think the utilization of like improving surgeon life, like quality of life, like in the OR and those sort of things, because I think that does impact like that email about closing TMJ things.
Mhm.
That part is just overlooked, and it's overlooked in training and it's overlooked in practice, and it's like we're superhumans that can just keep working endlessly, and that isn't the case. And so integrating like future things, for me the future thing is taking breaks. The other future things is in office like quality and research related things, because Andrea testing, let's say, nerves or looking for infections is different than me, right? Because again, it's good to have other set of eyes. So I think going into the future on further integration, I think that's probably where we're going to be.
Yeah.
So
Makes sense. All right.
Wasson,
Anything else, Andrew? You got anything else?
No, I don't think so. I mean, I really come to love jaw surgery over the years. So I find myself privileged to be in this position and to be at this practice. And yeah, it's been a good fit.
Is there an opportunity for your practice to train PAs?
interesting idea.
I think occasionally we'll have like PA shadow and things like that. It's just generally starting off like, yeah, maxillofacial is a weird.
Do they have rotations like that? Do they have
They have
clinical?
surgery rotations and elective rotations, so we could definitely get a PA student if we wanted to. But it'd be like a month long.
Interesting idea. I
Yeah.
mean, it's not
Yeah.
terrible. I mean,
You want us
I'm
to
full of
train
good
someone up
ideas.
and then send them to Arizona?
I wouldn't be opposed to the idea, but I think again, I might be in the nurse practitioner world down here.
I don't know if
Yeah,
I've really even considered that. Because
Maybe
we've had
rotation.
people come by, but
yeah.
it's an interesting idea for sure. So, because I don't know, it definitely is cool. Because jaw surgery is awesome. So
All
sweet,
right.
man.
Does anybody have any other old man Southern sayings they want to, or you got some Midwest ones, Andrew,
There's some
that
good
you
ones in
can?
there.
I think probably my dad's favorite saying is like 6 of one, half dozen of another, where it's like
Yeah.
the same thing. Have you heard that one?
Yeah.
Yeah, heard that one.
The other alternative is like tomato, tomato, potato, potato. Like it's a way of
Yeah, we
saying
don't
you're
want to
saying
burn
the
through
same
them all.
thing.
You know, you don't want to just not have any for future episodes.
Yeah.
So one day I might
feel
eat
like you're
them, so
feel like you're getting upset like this. Like you might be madder than a wet hen.
see, that's Arkansas
And
coming out again.
um, well then, we want to wrap this up.
Yeah, I think that's good.
Yeah.
Anyway, I appreciate Andrea joining. She put together some slides that we didn't use, but we were kind of using.
Well,
So
do we want to show them? Is there anything worth showing real quick, or are we past that?
I think it's
fine.
I think in the future we'll likely have Andrea on again to talk about things like assisting in surgery and things of that nature. But for now, thanks for joining up.
Yeah,
and,
no, thanks for having me.
Yeah, I think
Yeah, thanks for coming on.
everybody consider it. It's good. It's a good option.
All right. Yeah. Well, thanks for everyone joining us for another episode of the Down Fracture Podcast, a podcast for talking jaws. As always, downfracturepodcast@gmail.com. As by evidenced at the beginning of this episode, we do read them, listen to them. Some of the input has been phenomenal because we certainly are not all knowing, all powerful. And it's nice to hear other things that patients have or providers have encountered and ways that they do things that's probably better than ours in some instances. So
Yeah.
keep the emails coming. The fan mail's fun, great as well. And we'll see you guys next time.
All right.
All right.
See you later.
All right.
Bye.
See ya.